First, welcome Professor Greg Lipp from Birmingham University. He's going to speak first. Greg doesn't really need any introduction. He is a world leader in the research and development of treatment of atrial fibrillation. Thank you, Greg.
Thank you very much, Mr. Chairman, for the very kind introduction and also for the invitation to be here today. My remit is to talk on atrial fibrillation and hypertension, focusing on risks and clinical impact. And I just want to start off by saying that we're dealing with a commonest cardiac rhythm disorder, and if in this room we are age over 40, our lifetime risk of developing atrial fibrillation is 1 in 4. And if you look through epidemiological studies or trials, you will see that, and also population data, you will see that hypertension is one of the commonest comorbid factors, very often with atrial fibrillation or leading to atrial fibrillation. And in fact, as many of you are aware, I work in Birmingham and the hypertension clinic. I also run the hypertension clinic now, but certainly the hypertension clinic, we went through a phase where we thought we should call it the pre-AF clinic. You will see that this is a slide looking at the prevalence of hypertension in various AF studies, adding up to 90% associated with atrial fibrillation. Well, if you look through this pathophysiologically, you will see how atrial fibrillation is linked to the whole spectrum of the cardiovascular continuum associated with hypertension. Now, this is a figure from a position document from the ESC Working Group on Hypertension in the Heart. But you'll see, of course, hypertension is a risk factor here. But as we all know, how hypertension leads to various target organ damage manifestations in hypertension, whether that's left ventricular hypertrophy, associated coronary disease. You may look at also myocardial infarction and neurohormonal activation. Here we have, of course, with LVH, you have left ventricular dilatation and heart failure, and of course cardiac remodeling and atrial fibrillation very nicely at the center of all those manifestations of hypertensive target organ damage. One can even make the assumption that atrial fibrillation is one of the manifestations of hypertensive target organ damage. Why the interest in hypertension and atrial fibrillation? Well, the first point is related to the increased risk of stroke and thromboembolism associated with atrial fibrillation. And of course, hypertension features prominently. This is a systematic review published in 2007 from the Stroke Risk in AF Working Group, which I had the privilege to be part of. It largely concentrates on the data from the original randomized trials. Those were the days when you had a placebo control group where you can actually look at stroke rates. Now, the issue about the original trials is that the hypertension was defined in different ways, whether it's history of hypertension or uncontrolled hypertension with a systolic blood pressure of greater than 160, but you'll see a fair amount of consistency where there's an increased risk of over nearly twofold related to hypertension independently for stroke in atrial fibrillation. If you look through more contemporary data, and this is a data set from the Swedish Atrial Fibrillation cohort study, a cohort of about 182,000 patients with atrial fibrillation, it does bring about to attention some of the risk factors not evident from the original historical trials. Why do I keep calling it historical trials? They were done about 20 years ago. And if you look through the detail of those historical trials, as I mentioned, those are the days you could have a placebo or control arm to these trials against warfarin. If you look through the detail, less than 10% of the patients who were screened were ultimately randomized. Many risk factors were neither coded nor adequately or consistently defined. We now have data from large observational data looking at the impact, independent impact of different risk factors. And we see, for example, looking at age. Age is a very powerful driver of stroke risk. And the risk of stroke starts to rise from age 65 upwards. It's not 75. It's not as if you're 74 years and 11 months, you're low risk. And suddenly, based on old risk schema, even like the old NICE guidelines, once you get to 75, it suddenly becomes high risk. You will see that compared to age under 65, age 65 to 74, a 2.9-fold increase, 75 and above, 5.2-fold increase. Female gender, 17% increase overall, but there may be age dependency to this risk. No surprises here with previous stroke, 2.8-fold increase, but look at that relative hazard of 2.8-fold about the same as the relative hazard 2.94 of age 65 to 74. You will see here also vascular disease, largely driven by peripheral artery disease, a 22% increase in the risk of stroke. And here's hypertension, a moderate risk factor, about a 17% overall increase in the risk of stroke. You could almost say the relative hazard related to hypertension is about the same as female gender, is about the same as diabetes here, 19%, is about the same as, for example, previous revascularization or rather vascular disease. So moderate hypertension as a moderate risk factor. This, of course, has now been included in contemporary risk stratification schemes. And this is, of course, the CHA DS score, first introduced in the 2010 ESC guidelines and further reaffirmed in the 2012 focus update of the European Society of Cardiology guidelines. Now, why the difference with CHA DS? Basically, the ESC guideline recommends a risk factor-based approach to stroke risk assessment, because a stroke risk factor is a risk factor. And if a patient with atrial fibrillation has a stroke risk factor, the patient's at risk of stroke. In old currency, so to speak, the older guidelines recommended classification of patients into low risk, moderate risk, and high risk. Why? Because if you're going to, until a few years ago, if we chose anticoagulant therapy, all we had was a drug called warfarin. And if you're trying to give anybody this inconvenient drug called warfarin, you try and target high-risk patients. Now, the strategy you're trying to focus on high-risk patients certainly doesn't work, because if you look through lots of published data, there's substantial under-treatment of high-risk patients with atrial fibrillation. So the ESC guideline, as I will show shortly, focuses much more on risk factors and initially trying to identify low-risk patients. Now, the differences from the older risk scoring systems are highlighted in red. I mentioned before the risk of stroke starts to rise from age 65 upwards, so that gets 1 point. Age 75 and above gets 2 points. Then we have here heart failure, hypertension, diabetes, stroke, and then V now is for vascular disease, and then SC here is for sex category, female gender, and vascular disease, age 65, 74, and the sex category gets 1 point each to be the components of the CHA DS VASc score. Now, has the CHA DS VASc score been validated? There have been a number of validation studies that have been published. Here we have on the left table the old CHA DS score. This was the risk scoring system based on the original, from the risk factors identified in the original historical trials. And I mentioned the limitations of those historical trials already. Here we have the CHA DS VASc score, and if the CHA DS VASc score increases, you will see how the risk of stroke and thromboembolism correspondingly goes up. But I want to mention a couple of points here, because when you have a CHA DS VASc score of 0, the stroke event rate is 0.78% per year. And once you get to a CHA DS VASc of 1 and above, you see how the risk goes up correspondingly. In contrast, if you define low risk using the using the old CHA DS score, the stroke rate is still about 1.7% per year, which is not really that low risk. In terms of identifying high-risk patients, you can calculate what is called a C statistic, which is a statistical measure to tell you how good a score is to predict the patients who get events. Well, the C statistics for the CHA DS score is 0.72. CHA DS VASc is 0.85. You will see the confidence intervals do not even overlap. So CHA DS VASc is good at identifying the low risk, is certainly good at identifying the high-risk patients as well. Just to look at this from a different perspective, because in old guidelines, even the old American guidelines from 2006, even with recent updated text in some parts, it still defines low risk using the CHA DS score, the old CHA DS score. And this is an analysis where you look at CHA DS of 0, and these are 17,000 patients from the Danish nationwide cohort study. And if you subdivide them by CHA DS VASc, you will see that the stroke rate ranges between 0.8% per year going up to 3.2% per year. So 3.2% per year stroke rate if left untreated, that is not low risk. And if you assume that a CHA DS score, the old CHA DS score of 0 is low risk, there's two aspects there. Firstly, you are kidding yourself. Secondly, you're putting patients with AF to be at risk of fatal and devastating strokes if they have atrial fibrillation. So take-home message, CHA DS score of 0 is not low risk. If you want to identify low-risk patients, you clearly can do that with a CHA DS VASc score. Now, the H in CHA DS VASc, or for that matter, the H in the CHA DS II score, that's supposed to mean hypertension. And there's a recurrent debate. Does that mean history of hypertension, or does that mean uncontrolled hypertension? And just to put this into perspective, these are data looking at blood pressure and event rates from an anticoagulated cohort. This is the sportive trials. And just to say that, concentrate here, please, on just the warfarin-treated patients in gray here. Looking at the quartiles of blood pressure and event rates, you will see that the event rates very clearly have this nice step up with increasing quartiles of blood pressure, suggesting that with uncontrolled blood pressure, the risk goes up correspondingly. However, you can analyze this in a different way. This is looking at the average systolic blood pressure, looking at event rates. Well, if the blood pressure is well controlled, event rates are low and fairly flat. And once systolic blood pressure becomes uncontrolled beyond 130, you see how this rises correspondingly as well. So re-emphasizing the point, as with much of blood pressure management, blood pressure control is absolutely crucial even in patients with atrial fibrillation if you want to minimize stroke and thromboembolism rates. And indeed, if you look through other observational data, this is from an Italian cohort. And I just want to draw attention to the presence of hypertension on multivariate analysis, the odds ratio for increased ischemic events, particularly cerebrovascular events. And if the patient has had a previous thromboembolic event, you combine it with hypertension and a previous thromboembolic event, you see how the odds ratio for increasing complication goes up substantially. So hypertension alone, increased stroke and thromboembolism. If you have other risk factors, and in this example, previous ischemic event, you add hypertension to ischemic events, you already substantially increase the risk more than twofold in terms of stroke and thromboembolism. In terms of risk, now I mentioned earlier, overall on a population basis, female gender increases the risk of stroke. Now, females are always very interesting if you're looking at stroke risk and atrial fibrillation, and much attention has been directed to try and see the reasons why this may be the case. And this is one example. Maybe it is because of background hypertension. These are data from the ATRIA study, and looking at diagnosed hypertension event rates amongst women compared to diagnosed hypertension in men. So 4% per year compared to 2.4% per year, this may be a risk factor. We ourselves have looked at other reasons why female gender may increase stroke risk. It may well also be renal reserve. It may well also be, especially amongst anticoagulated patients, the poorer quality of anticoagulation control. I'm going to turn now to another aspect of stroke prevention, atrial fibrillation, because if you give anticoagulant therapy, you're trying to reduce stroke. The downside, of course, is the risk of bleeding. And just to say that hypertension does feature in most bleeding risk scores, the one recommended in the ESC guidelines is the HAS-BLED score. I'll take you through the acronym. H, the first one here, H is hypertension, essentially uncontrolled blood pressure. A is for abnormal renal or liver function, that's 1 point each. S is for previous stroke. B is for bleeding tendency or predisposition. L is for labile INRs if the patient's on warfarin. E is for elderly, arbitrarily defined by age, but the reality is really biological age. So if you've got a patient in frail or poor condition, that really is 1 point as well. Drugs is for concomitant use of aspirin or nonsteroidals with anticoagulants, or alcohol abuse or excess. And the maximum HAS-BLED score is 9 points. And as the HAS-BLED score goes up, you see how the risk of bleeding goes up correspondingly. Then when the HAS-BLED score is 3 and above, the risk starts to jump quite substantially. Now, I would make the point that the HAS-BLED score was not designed as an excuse to withhold anticoagulant therapy. The ESC guidelines very clearly state the HAS-BLED score is for you to flag up the patients potentially at risk of bleeding for more careful review and follow-up. And furthermore, is to make you think about the correctable risk factors for bleeding. For example, the H, uncontrolled blood pressure. So therefore, control the blood pressure. The D is for concomitant aspirin with anticoagulants. So you take away the aspirin, you reduce 1 point on the HAS-BLED score to try and reduce the risk of stroke, risk of bleeding, or particularly intracranial bleeding, which is the most severe form of bleeding with anticoagulants. Does the Hasbled score work? This is an example again from the Swedish AF cohort study. And I'll just draw your attention to increasing Hasbled score. You see major bleed rate on warfarin going up correspondingly. You see the major bleed rate on aspirin also going up correspondingly. You can look at a more severe spectrum, which is intracranial bleeding on warfarin, intracranial bleed on aspirin. But that's another interesting observation from this study. Look at the major bleed rate on warfarin compared to major bleed rate on aspirin when you stratify them by Hasbled score. They really look fairly similar. Here is the intracranial bleed rate on warfarin, intracranial bleed rate on aspirin. You see again, stratified by Hasbled score, rather similar across the way there. So given that aspirin has very minimal efficacy for stroke prevention in the setting of atrial fibrillation, and as you can see from this data, it's not really much safer than warfarin for major bleeds or intracranial bleeds. That is why most of the contemporary guidelines have really downgraded the use of aspirin for stroke prevention in atrial fibrillation. Just to illustrate a point how hypertension increases the risk of bleeding, and this is one example, just to show that hypertension increasing the risk of intracranial hemorrhage, nearly about 2.6-fold. This is on multivariate analysis. Other predictors were things like durational anticoagulant therapy, and no surprises if the INR gets above 4.5, which again re-emphasizes the point hypertensive patients require very close monitoring and really optimal control of their blood pressure. Now, I've mentioned a lot about stroke, I mentioned a lot about bleeding, and how do you put this together? Well, you're really, in the end of the day, trying to balance, for your patient in front of you, trying to balance stroke against the risk of bleeding. And you can do this in numerous ways. The most simplistic way is to look at the magnitude of prevention of ischemic stroke versus the potential for harm with the most serious bleeding, for example, intracranial bleeding. So it's a form of net clinical benefit analysis. And this here is one of a number of papers that have been published looking at this. On the y-axis, we have increasing bleeding risk with a Hasbled score. On the x-axis, we have increasing stroke and thromboembolism risk by the CHA DS VASc score. And you'll see that in every quartile here, you see anticoagulated patients, that's the red line, doing far better than non-anticoagulated patients in the white line, with the one exception, a CHA DS VASc score of 0, because at a CHA DS VASc score of 0, in fact, those patients did not derive any appreciable net clinical benefit in favor of anticoagulation. I would point out that at no level of stroke or bleeding risk did aspirin have any positive net clinical benefit. And this, as I mentioned, is already a data set of 180,000 patients with atrial fibrillation. So, what do the guidelines tell us? The ESC guideline flowchart is here. The guideline in 2012 emphasizes a very important clinical practice shift. I mentioned before, prior guidelines focused on identifying high risk. This guideline now strongly recommends a greater focus towards initial identification of low-risk patients, and these low-risk patients do not need any antithrombotic therapy. And the flowchart is shown here. In fact, simplicity is in this flowchart, because the first decision step within the red box, age under 65 and lone AF or a CHA DS VASc of 0, yes, it's a little bit of duplication, but it's re-emphasizing the point that these are low-risk patients who need no antithrombotic therapy. Subsequent to that initial step, the next step then is to offer effective stroke prevention to patients with AF and one or more stroke risk factors. And effective stroke prevention is oral anticoagulant therapy, whether that's delivered as one of the novel oral anticoagulants or whether that's delivered as a warfarin. That's up to your healthcare system. I wish to turn very briefly to atrial fibrillation and antihypertensive management, because many of us are aware of data how the renin-angiotensin system seems to help in relation to atrial fibrillation. But I would just want to point out that the data for hypertension aren't necessarily so good. This is looking at the prevention of atrial fibrillation with renin-angiotensin system blockade, and you will see here the hypertension studies, some don't really show this, well, some do. However, if you look at heart failure or you look at rhythm control studies, this seems to be more evident. And this is a busy slide here, but I just want to highlight here again, numerous meta-analyses have in fact come to the same conclusion in terms of renin-angiotensin inhibition, in terms of preventing atrial fibrillation, It's 11% reduction, but the confidence intervals include one not significant. This is in contrast to patients with heart failure, post-cardioversion, or patients just on medical therapies. However, hypertension seems to have attracted interest in terms of rhythm progression. And this is a study which, from the EuroHeart study, where it proposed the Hatch score, where hypertension is in the H there, because as the Hatch score goes up, you see the risk of progression goes up. And in fact, hypertension independently increased the risk of AF progression by 1.5-fold. But the intervention studies, some of the intervention studies may well suggest this. This is looking at a randomized trial comparing amiodarone versus amiodarone plus losartan versus amiodarone plus perindopril for the prevention of AF recurrences in lone paroxysmal AF. And you will see here the two groups there, with one with losartan, the one with perindopril did far better than the group which had amiodarone alone. So just there's some benefit for this. However, in terms of the rhythm management strategy, one prospective randomized trial came out last year. This is looking at patients post-ablation, and this was a little bit of a strange trial because the primary endpoint was looking at atrial fibrillation burden. And as you can see, the placebo patients or the ARB patients with olmesartan really didn't show any difference. If you look at one of the secondary endpoints in terms of AF recurrences, you see the Kaplan-Meier curves don't actually show much benefit. So what I'm really saying is that the jury is still a little bit out when you're thinking about AF in relation to treatment hypertension with renin-angiotensin blockade in terms of rhythm progression. So let me conclude, Mr. Chairman and ladies and gentlemen. Hopefully I put across to you that AF and hypertension are very intimately related. That's both epidemiologically, pathophysiologically, and prognostically. Management of AF requires aggressive treatment of comorbidities, and hypertension is clearly at the center of that. Uncontrolled hypertension is a risk factor for stroke and bleeding, and very clearly within the risk scores within ESC guidelines such as CHA DS VASc and HAS-BLET. The drugs for hypertension, particularly renin-angiotensin system blockade, may influence AF and its complications, although the benefits of rhythm progression are uncertain. And with that, thank you for your attention.